The human orbit is without a doubt one of the most densely packed, high-stakes neurovascular intersections in the entire body. When a mass or lesion develops in this tight space, it inevitably compresses multiple adjacent systems simultaneously. Because of this anatomical crowding, the resulting clinical symptoms like proptosis, diplopia, and acute vision loss often present uniformly, regardless of the underlying disease. Relying on this symptomatic overlap, or trying to group diseases into broad categories like neoplastic versus inflammatory, is highly unreliable. We have to abandon the symptom-first approach and instead filter these pathologies through strict spatial geography. By first isolating a lesion to a specific anatomic compartment and then applying targeted MRI functional signatures, we can systematically eliminate lookalikes and pinpoint the exact etiology. This normal anatomy map segments the orbit into mutually exclusive zones: the central intraconal fat space, the muscular conal compartment, and the peripheral extraconal space. Finally, we isolate two highly specialized structures: the optic nerve sheath complex and the superolateral lacrimal apparatus. Location dictates statistical probability. Pinning a lesion's exact coordinate to one of these 5 zones instantly narrows the differential diagnosis. This anatomical diagram illustrates the optic nerve sheath complex. The optic nerve is the only cranial nerve wrapped in meningeal coverings, surrounded by the dura mater, arachnoid, and pile plexus. When a patient presents with acute vision loss, the radiologist must determine if the threat is external compression from these surrounding meninges or internal necrosis of the nerve itself. The primary suspect for external compression is an optic nerve sheath meningioma, an uncommon benign tumor arising from the meningiothelial cells. This axial gadolinium-enhanced T1-weighted MRI reveals the specific signature required to prove this diagnosis, the tram-track sign. Here, the contrast agent pools in the highly vascularized tumor of the meninges, forming distinct, bright parallel lines, while the healthy nerve tissue in the center remains dark and non-enhancing. Conversely, the primary internal threat is ischemic optic neuropathy, or ION. This acute condition is caused by vascular insufficiency, leading directly to nerve necrosis. ION will not produce the tram-track sign because the meninges are unaffected. To detect it, we need a different MRI sequence. These axial scans show diffusion-weighted imaging, or DWI, and its corresponding apparent diffusion coefficient map acting as the critical tiebreaker for internal nerve damage. The bright, localized restriction you see within the left optic nerve pinpoints the exact location of cellular death and ischemia within the nerve fibers. Within the ONSC, contrasting T1 enhancement against diffusion-weighted imaging separates a structural tumor on the outside from an acute ischemic stroke on the inside. Stepping outward, we reach the conal space, which is defined by the extraocular muscles responsible for eye motility. The primary radiological presentation of pathology in this compartment is gross muscle enlargement, which physically restricts movement and causes diplopia. The most common culprit for this enlargement is thyroid eye disease, an autoimmune disorder of the orbital tissue, also known as Graves' orbitopathy. This generated medical illustration shows the morphological tiebreaker for thyroid eye disease. It inflames the muscle belly, creating a bilateral Coca-Cola bottle enlargement, but characteristically spares the thin tendinous insertions attaching to the globe. This Coca-Cola bottle sign is the reliable hallmark of the osmotic edema and fibrosis caused by thyroid-related inflammation. A secondary diagnostic pattern for thyroid eye disease is the I'm slow mnemonic, which outlines the hierarchy, starting with the inferior rectus, followed by the medial, the superior rectus, lateral, and oblique muscles. We must contrast thyroid eye disease with its primary clinical mimic, idiopathic orbital myositis. This coronal fat-saturated T2-weighted MRI shows that while myositis also causes acute muscle enlargement and pain, its morphology is distinct. The inflammation involves the entire muscle unit, including the tendon. This lack of tendon sparing, combined with what is typically a unilateral presentation, strongly points to inflammatory myositis rather than systemic thyroid eye disease. However, we must consider a wildcard scenario: severe extraocular muscle enlargement that presents with absolutely zero clinical pain. These axial MRI scans show an infiltrative mass. When you see painless, unilateral muscle enlargement coupled with heavily restricted diffusion on ADC maps, it indicates a neoplastic cause, such as lymphoma or metastases. In the conal space, tracing the inflammation to the exact point where muscle meets tendon separates a systemic autoimmune disease from a localized infection or malignancy. Moving to the deep retrobulbar fat of the intraconal and extraconal spaces, we frequently encounter isolated mass lesions. The most frequent benign mass found in the adult orbit is the cavernous venous malformation, or CVM. The radiological challenge is that on standard scans, a CVM perfectly mimics a schwannoma, a nerve sheath tumor. Both appear as well-defined ovoid masses. These axial MRI scans demonstrate a necessary diagnostic tool, dynamic imaging, to track the timing of contrast filling. The specific signature of a CVM is progressive enhancement. Contrast enters sluggish venous pools slowly, eventually filling the entire mass homogeneously on delayed images. We contrast this slow timeline with the schwannoma, which typically exhibits immediate avid enhancement due to its dense capillary structure and high cellular density. This kinetic difference in contrast uptake over time allows the radiologist to definitively distinguish a blood vessel anomaly from a nerve sheath tumor. When the morphology of two lesions is identical, mapping the velocity of a contrast agent provides the definitive diagnostic answer. Precision in orbital radiology requires a strict two-step algorithm. Step 1 is geographic localization. You must force the lesion into a specific anatomic compartment, whether that is the ONSC, the conal space, or the retrobulbar fat. Step 2 interrogates tissue behavior, mapping findings on a decision matrix using functional MRI signatures to eliminate lookalikes. Check diffusion-weighted imaging for ischemia or lymphoma thresholds. Evaluate tendon morphology to confirm thyroid eye disease, and track contrast kinetics to identify venous malformations. By anchoring the differential to anatomy first and functional MRI signature second, radiologists can cut through the clinical noise and deliver a definitive diagnosis.